Thank you for joining our health program, Comfort, Compassion, and Caregiving at the End of Life, brought to you by the East Brunswick Public Library's Health Initiative, Just for the Health of It. This is solely for educational purposes. Our presenters cannot provide personal medical advice. As a reminder, this event is being recorded, so please be mindful to not give personal health information and do not ask for specific personal medical advice throughout the entire presentation, including when we get into our question and answer section of the program. This presentation from Astera Cancer Care explores the essential role of family caregiving during the end-of-life journey. We welcome our speakers, Sally Johnson and Nishama Marcus. Sally is a palliative care provider at Astera Cancer Care and works with patients and their loved ones to assist in relieving the stress and suffering of their disease and its treatment. Sally specializes in pain and symptom management with a focus on quality of life. She focuses on improving patients' comfort and including the patient and loved ones in the care plan to ease burden and prioritize patients' comfort and well-being. Nishama is the Director of Social Work at Astera Cancer Care and provides concrete and supportive services to patients and their families as they navigate the cancer journey. As a therapist, Nishama practices with empathy and compassion, meeting each patient where they are at. As an administrator, she aims to enhance patient access to quality care by addressing social determinants of health at the individual and macro levels. Nishama has advanced certificates in gerontology and grief counseling. I will now hand the floor over to Nishama Nishama first, afterwards Sally. Thank you.
Chief my name is Nishama, Director of Social Work. I'm happy to be presenting alongside my colleague, Sally. I included our contact information here. I also included it at the end during the downline, so you can give a question that you want to ask after, or you can ask the questions. So before we get started, I wanted to just outline some of our goals for today. What we're hoping will be the key takeaways. So first, we just want to highlight how essential the role of caregiving during the end of life. When we say end of life, I think we all talk about the thing until the end. We're not only talking about the final moments, we're also talking about from the time of diagnosis or from the time you learn about terminal illness, which could be several sick. When we're talking about the word caregiver, we're not necessarily talking about one work days. We're also talking about family members, and friends, and neighbors. You may hear us use the term loved one. That's an all-inclusive term, actually just on all of these types of things. We're hoping that caregivers will feel more equipped to provide compassionate care. And we're also hoping that caregivers will understand not only the physical care given, but also the emotional aspect and what they can be to prevent caregivers burnout. So this is our agenda for today. We're going to first be focusing on the patient experience, making note of the emotional, spiritual, and physical needs, and then we're going to hop into the caregiver experience. We're going to be discussing caregiver capacity, what it takes to be an effective caregiver, what to say, what not to say, and why, and how to care for the caregiver.
When we think about patients' emotional needs, we talk about the fear of pain. What suffering will look like? Will I be able to tolerate the pain? What was my tolerance like in the past, and how will I cope in the future? Patients are often worried about what's going to happen to my body, how will my body work its way towards shutting down, and what's going to happen to my soul or my spirit. Patients talk about fear of the future of their family. What's going to happen to my family? What's going to happen to my friends? I've heard patients talk about, like, I keep picturing my loved one crying. They're not going to be able to move on without me. Who's going to take over my tasks? And sometimes that's like succession planning. Like, I'm the one who always handles the finances. I'm the one who always takes out the trash. And what's going to happen to the family system without them? Financial insecurity. I often hear it like, Like I've had a patient say to me that I had hoped to save more. And so I'm not leaving folks in good standing. Um, or like I'm leaving my family with debt or things like that. Patients talk about functional loss. Um, how can I slow down the functional loss? Every time something doesn't work right, it then prompts me to feel anxious about the next thing that's not going to work right, and then something else doesn't work right. And what can I do to kind of slow that down? Patients talk about loss of interest. So I might have really enjoyed gardening, but what's the point? Why bother? What's my sense of purpose? Loss of control. How do I sustain that feeling of control when my body feels just so out of my control? Folks talk about becoming dependent or feeling like a burden. So a lot of times people will say like, I want to clean my house out before I shut down completely because I don't want to leave my family with all this mess. I don't want to add to their burden. A lot of times people try to like make themselves small, like, well, I don't want to ask my family member to do anything because I don't want to put more onus on them. They're already dealing with so much. They talk about regret or guilt. Um, Sometimes it has to do with like their poor actions or things, bad choices that they've made in their life. And sometimes it has to do with just bad experiences we've all experienced together. But what was my role in it and how did I contribute? And then there's a general feeling of fear of not wanting to disappoint their family. Like my family wants me to keep fighting. I don't feel like it. I feel exhausted, but I don't want to disappoint my family. Things like that. Okay, so now we're going to talk about spiritual needs. So the first one, the need for meaning and purpose, and we kind of alluded to it before, but it's really wanting to understand what was the purpose of my life, what's the purpose of my illness, reflecting on my accomplishments, my regrets, my life choices. I want a reassurance that my life has mattered, whether it's to like somebody in particular or that I wanted to leave the world a better place than when I first came and that my life meant something. For love and connection, there's like the desire to feel loved, but it's also like that feeling of not wanting to abandon and not wanting to feel abandoned. Um, Sometimes this has to do with like feeling strain or unresolved relationships. So a good example would be like I haven't spoken to my sibling in 50 years. We had a big falling out, but now end of life, I might want to reconnect and see them one last time. And it kind of seems out of the blue. It's like it didn't matter to you yesterday, and all of a sudden it's very important to you today. The need for peace and acceptance, seeking emotional peace, spiritual peace. Sometimes it's coming to terms with mortality, knowing that I'm not going to be here anymore and feeling okay with that. Sometimes it leads actually to issues of legacy, which I'll talk about in just a minute. That if I'm not going to be here anymore, then how do I keep my legacy going and preserve the space that I've created for myself? Sometimes there's a need for forgiveness or reconciliation, that I want to be forgiven by other people, or I want other people to forgive me for things I've done. And I call that tying up loose ends, right? So just going back to legacy for a second, I want my story to live on. You might hear people write memoirs at end of life and think, it's kind of part of that legacy and wanting to pass down. For some folks, it's heirlooms or passing down wisdom or, getting my story out there. The need for control and autonomy. A lot of times this has to do with like, I want to have a say in my care. I want to be respected in my planning. For some people, it's like end of life wishes or funeral preferences, and it can become morbid, when they kind of initially talk about it. But it's really just their way of preserving autonomy and independence. The need for dignity. Folks want to be seen as valuable. They want to feel that they're worth it, that they're going to be treated with respect. They're going to talk about this too. They want to belong to something larger. For some people, that's like reconnecting with a higher power, reconnecting with humanity or their community, or just getting a general sense of meaning. And then for some folks, I mentioned the reconnection with faith. For some folks, they might urgently want to speak to a clergy member, or, do you know anybody that does this, that will come to the house and, do prayers with me? It's just part of that need.
Hi, I'm Sally. So as she said, I'm the palliative provider at Astera. And as I go through this, I'll explain more what palliative is. But I'm going to cover the physical needs of the patient. And let's see, I'll start with palliative. Palliative is, it's important to know the difference. Palliative, when said to a lot of people, they think hospice and they think kind of along that same line. There is a big difference between palliative and hospice care. Palliative care is more of a symptom management for any stage of a life-altering disease. The patient can still be looking for all curative treatments, can be getting physical therapy, can be getting chemotherapy, whatever, and they can still qualify for palliative care, which is another set of eyes, another set of hands in their care to further help them with whatever they are going through physically. Where hospice is more once somebody has decided or there's no option for any curative treatments for whatever they might be going through. And they're ready, they're tired of the doctor's appointments and the hospital visits and everything. And they're all about, at that point, quality of life and just focusing on that. And then hospice comes with a lot more assistance in other means, where palliative is another provider to help. And then hospice has other means and home health care and such like that. So depending on the patient, on what they need. And there's an appropriate time for each. But our loved ones have physical needs at the end of life that are very important. And they can be very challenging on the caregiver. As they're tough on the patient, that can also have the effect on the caregiver. It's hard for the patient to give up and know that somebody else needs to take care of them and to help provide their physical wants or needs. At times, our patient can become confused or nonverbal, and we need to be right on top of what they're going through just by assuming, and they can't always tell us. So it's a big burden on us to recognize the change in them. We can watch for the mood changes from the regular personality, restlessness, being short-tempered with us, loss of appetite. And I think one of the challenges in being their caregiver is everything I just mentioned can be a symptom of anything they're going through. It can just be their frustration with their situation, or it might be that they're feeling pain. It might be that they've been incontinent and they're wet and they're uncomfortable and they don't know how to even tell you that. So there's a lot of crossover, and it becomes a lot of challenge to figure them out, and it's going to be trial and error, and you're going to do the best you can do. And let's see, I want to kind of say, I'm talking generally about their physical needs. The most important thing is to talk to that person's caregiver, that primary care, whoever's taking care of them, to discuss what medications they need, when to give them, anything like that. As I go through slides, I'm going to talk about medications, but ultimately it will be on what their provider, has prescribed to them or suggested that you give. And so physical needs, first we have, a few here, pain and discomfort, constipation, incontinence, and nausea, breathlessness, restlessness, anxiety and stress, and then just basic skin, mouth care, and their comfort. These are just a few of the things that they may experience. The pain and discomfort, they might just be able to tell you that they're in pain. When it's felt, it can be spoken, or it might be in the restlessness and agitation and anger, or withdrawal. You might notice a difference in their breathing. Anything that you notice different is worth looking into more to see if there might be something causing them discomfort and pain. And it's very important to properly treat pain. And this I kind of want to focus on a little bit, because with my patients and speaking to their caregivers, there's a lot of fear with helping somebody deal with their pain. There's fear of opioids. There's fear of giving medicines. Maybe the medicine makes them sleepy and you feel like, oh, I'm over medicating. All they're doing is sleeping. But maybe now they're finally pain-free and they can relax and actually be comfortable and rest, which they hadn't been able to do. If the prescription is written by a provider that knows everything going on, it's generally safe to follow what they say. If they say they can have 1 or 2 tablets every 4 hours, and you see these changes, and maybe you've tried everything. You tried to give them something to eat. You tried to give them something to drink. Nothing's working. It might be the pain, and it is important to treat the pain. We don't know what they're feeling on the inside. Even people that are verbal, but I have a lot of patients that are very stoic, and they don't want to admit that they're hurting, but you see it, and you see the short-temperedness on somebody that's never short-tempered with you or something. It's important to make sure it's not pain. And to reassure them that it's okay to take their pain medication and to admit that they're hurting. Nobody needs to suffer. And that's really what this is all about, trying to give them the best quality of life at this time. And let's see. There's these other treatments. There are the opioid medications that I just talked about. There's non-opioid choices, which once again, their provider, can give you a list of what's safe for them to take. Even over-the-counter pain medications do have side effects or can have negative. So it's important to discuss all of that with their provider to make sure, which thing is safe with whatever's going on with them. Physical therapy might be something that's helping them, especially if they're a little bit inactive, just moving the muscles around and getting them active. Gentle exercises, massage, proper positioning. If they're unable to just, they're not really that mobile around anymore, they need assistance getting in a proper position. It can cause a lot of discomfort. Other physical needs, constipation. Constipation is a very common issue. It can be because of the medications, pain medications, increased constipation, but also lack of mobility, just that they're not active. Everything slows down, and that includes their gut, and they're not going to have bowel movements normal. It's important to keep hydrated. You constantly offer water, proper diet, if they're eating well for you, and to talk to their provider to see what medications can be given to help them. It might be a pain that's very easily taken care of by giving, stool softeners or whatever's recommended, and you can give them a lot more comfort. And it can be an embarrassing issue for them to talk about. So try to maintain their dignity when you talk about their bowels or their bladder. And with the incontinence, especially with maintaining the dignity and keeping the skin dry, if they're not eager to be telling somebody, they wet themselves, to not without any accusation, just be like, hey, why don't we just change the sheets? Why don't we change the pad? And try to help keep that area clean and free of wounds. Nausea is another common thing towards the end of life. It can be the disease process. It can be the medications taken. There are homeopathic remedies. You can try different teas, peppermints, ginger, lemon, aromatherapies, and then hydration, once again, can help with nausea. Hydration and properly getting in your water can help with many side effects more than just being, quote, dehydrated or just being thirsty. It really helps with your body functions in all ways. Skin and mouth care. It's very important. A lot of times people become kind of more mouth breathers, very dry, cracked lips. And sometimes they're not drinking so well for you. So maybe giving a wet cloth to suck on, or they sell like sponges on a stick that you can put in water and just suck on. Popsicles, lip balm for the lips. And then this picture here, it's a little blurry, but it shows pressure points. And when somebody isn't moving around much, these are like bony areas and areas that can end up with sores from not moving around enough. Even the earlobe, you know, people don't think of it, but constant pressure on that can break down. All of a sudden you see a little redness, and that's the warning sign that something's starting. It's important, like every 2 hours, to kind of get them to reposition, whether that's having a pillow on this side that just takes a ½ inch difference, and then removing the pillow in 2 hours. That right there changes the blood flow. It changes the pressure. It's not always easy to move people around a lot. They might be in pain and they might find only one position is comfortable to them, but do your best. You know, give pads under the heels, pillows under the back of the legs to keep the heels up off of, you know, the chair or the bed, whatever they're in. But it's important to pay attention to these areas. We can't always avoid it, but if we know they're there, then we can talk to their provider and get wound care coming in, or somebody to come in and help you to properly take care of any areas that might be breaking down. Okay, now the breathlessness, restlessness, anxiety, and stress, they're usually just something showing something else is going on. You know, whether that might be that it's time for their pain medication, that they're starting to come back and the pain is increasing. Maybe they've not had a bowel movement. Maybe you didn't really realize, and today they haven't moved their bowels or anything. They're starting to get uncomfortable. They could be hungry or thirsty if they're nonverbal or disoriented and they can't tell you those things. Any of these can be signs that those need to be checked and kind of things offered to them for comfort. You can check those issues first, and then maybe just hang out with them, talk, hold hands, just be there for them. Maybe that's all they need at that time. They might be focusing on their situation at that time. They might be worrying. They know that they did just have a bowel movement 2 hours ago and it was a mess and they made you guys clean it, and they feel horrible, or, you know, you just never know kind of what's going on in their mind at that time. Once again, remember, it's always important to keep their medical provider aware of any issues that are going on, and any concerns you have. And then with the hospice, as I was talking about, once a person is no longer able to care for themselves and there's no curative treatment, it might be time to talk to somebody and get more information about hospice. There's a lot of misconceptions, and people tend to think of hospice just, okay, well, you know, there's a couple weeks left, I'm going to call hospice in. In all honesty, it's a insurance benefit you pay for. And if they can benefit from it, if having a healthcare aide come in a couple times a week to help, even if the person's still showering themselves, but maybe the family's more comfortable knowing somebody's sitting in the next room. And at that time, the family member can go to the store, or the family member can take their shower or go to their doctor's appointment. These things are important. So it's for the caregiver and the patient that at the right time, this might be a good option for you. And there's also home palliative care that sometimes that can be helpful as well. And sorry, I hadn't moved on to the slide. But it's an important thing it can never hurt to have too much information. You know what I mean? So even before that time, to talk to somebody, go, what are the offers? How does somebody qualify for any of these services? What does it mean? Some people, once I say to them, okay, let's talk about hospice, they think that their loved one's going to have to stop taking their diabetes medications and their blood pressure medications, and they're going to just start taking a lot of pain medications and go to sleep and not wake up. It's not an accurate description. They have to stop curative treatment. Insulin's not curing their diabetes. That's keeping them comfortable because they're diabetic, you know? So there's just different things. It's important to have all factual information when it's time and then make an informed decision. Whether that is your decision, then it comes down to you knowing and you just, seeing what fits for you or what fits for your loved one. But it's good to know and to know all your options. Okay, I think that's it for me.
Thank you. Oh, good one. Me, I'm back. Okay, so now we're going to move from, so I'll make sure people can hear me. We're good? We're going to move from the patient experience into the caregiver experience. Okay, so when we think about caregiver capacity, we're talking about the ability and the resources of the caregiver to meet all of those needs that we were talking about of their loved one, right? The physical, the emotional, spiritual, practical, right? So we're going to go into each one of these. So when we talk about the physical care and assistance, many cancer patients, and keep in mind that we are cancer care, right? So a lot of this is focused on cancer. Patients experience fatigue, pain, mobility issues. So caregivers often assist with personal care, which is like bathing, dressing, toileting, grooming. They help with meal preparation, everything from like food shopping to light meal prep to cooking, ensuring that the patient has proper nutrition. We talk about medication management, which is everything from making sure that the medication list is up to date, making sure that the patient's following the prescribed schedule, how the medication's being stored, how it's being handled, who's handling the refills at the pharmacy. It includes mobility, like walking or transferring from like a bed to a chair or from a chair to standing. And it includes like symptom management, like monitoring side effects and connecting with the care team. So that's all responsibilities of caregivers sometimes, right? The caregiver capacity also includes knowledge and skills. So it's understanding the medical aspects of the care and making sure that they know like all of the medical conditions, the symptoms, what to look for, what the treatment options are available to them, knowing the side effects, how to manage them, administering medications or injections or, the actual home health care. Sometimes it's like being savvy on medical terminology, how to connect with the care team, right? That's all included in the knowledge and skills, right? Then there's like the communication. So strong communication skills are super important for caregivers. Not only do they have to interact with all these, healthcare folks, they also have to do like the advocacy work. They have to have the conversations with the patient, which sometimes there's conflict, right? So they have to be able to have those interpersonal conversations and sensitive conversations and taking the patient's needs into consideration. They might have to coordinate with all the other family members. I'm from a huge family, so having to like gather everybody's, feelings about it and advice, and everyone's an expert, being able to coordinate everybody. Caregivers assist possibly with financial assistance. So like treatments, appointments, co-pays, all that can be very expensive. And sometimes that can add stress to the caregiving role. Sometimes it's even like, if you're transporting them to appointments, it's just the the gas and the impact on the car. Like you kind of absorb it, not realizing how the stress that it takes. They might be responsible for like handling insurance coverages or getting financial aid, managing household expenses. Maybe your family member moved in with you, and all while navigating like your own responsibilities, right? And sometimes it has to do with like disability or paid family leave and getting all those into place. Then there's also like logistical support. So this to me is like doing like the scheduling of the medical appointments or arranging the transportation or organizing the household responsibilities around this person. Something that comes up too for us is like you might have like the sandwich generation. So you might be providing care for like an older adult who's ill, and you also have childcare. So like who's helping with the childcare piece of it? I'm putting stress management and resilience to the side because we're gonna discuss that in like several slides. Personal motivation and interest. When we talk about like caregiver capacity, to me, it's like how willing are you, how able are you, how interested are you in meeting this person's needs. So sometimes you can have like a tumultuous relationship and you might not want to provide care to this, family member or loved one. I think sometimes people feel like obligated or resentful that they have to provide care. So all that's included in motivation and interest. So the goal is to like find small moments of joy, small victories, and gain support from other people. Caregiver capacity also for me includes social support. So it's like I might be a really great caregiver, but if I have no support, nobody can work 24/7. It's just not possible. So if I have other people that can assist in the tasks, whether it's other family or friends or faith-based communities or volunteer organizations or paid caregiving or respite options, that's all part of the like social support network. I think that, it's last, but it's definitely not least, flexibility and adaptability. To me, like illness journeys are unpredictable and your needs change and the care receiver's needs change, and just being able to kind of constantly adapt to all that. You might have like new treatments or like unexpected hospitalizations come up all the time or shifting needs. So all these factors influence a caregiver's effectiveness. I'm looking at the clock. I'm like, there's so much. I think it's just important to note that caregivers' capacity can change over time. That's the most important part of the slide. Your capacity as a family caregiver is essential, and it helps you, and it also helps the person that you're providing care for. I have a lot more on that slide, but we're going to let it go. To be an effective caregiver, you have to have empathy. So I just want to talk a little bit about the difference between sympathy and empathy. So for me, sympathy is like a feeling of pity or sorrow or feeling sad for this other person's misfortune. It's like an emotional response, but it has nothing to do with the person you're providing care for. It's like separate from them. So you might hear people say like, I'm sorry for your loss, or that sounds really tough. And there's kind of like this disconnect of the person that you're providing care for. Empathy, on the other hand, is trying to understand what the person's actually experiencing, right? So it's like walking in their shoes. You're trying to feel what they're feeling. So saying things like, I can see how you would feel this way, or I just want to sit here and be present with you. Tell me what's going on with you, is helpful. And I think the overall goal of empathy is not trying to fix the problem and just being present. Okay, so when we look at empathy, what we're looking at is emotional presence, being there without judgment, accepting the full range of emotions, allowing for clear communication, open communication, and facilitation of communication among all the people that are involved, all the stakeholders. We talked about practical care skills. So most important, you don't need to be a nurse or a home health aide. You just have to listen and hear what the person's saying. If it's not you, it's somebody else. So if you're not the person that's able to kind of do all these things, the goal is to access the people that can. Okay, so honoring choice and autonomy. Folks in their last days often want to have a say about who they want there, where they want to be, how they're kind of defining what the comfort's going to look like. So avoid imposing like your own preferences on what they're experiencing. You want to create meaningful connection. So like share stories with them, look at photos, discuss what matters to them. Small rituals is helpful, like playing their favorite music or, reading aloud with them or kind of just engaging in meaningful conversation. I think to be an effective caregiver, you have to really establish boundaries. And I know that that's like a catchphrase. But end-of-life caregiving to me is like physically taxing, it's emotionally taxing. So it's important to say what you can do and say what you can't do. It's so much better to say, I can't do this, I'm not the right person, than to say yes and either not show up for the person or to show up poorly. And the way I see it is like a coworker. It's like you don't want your coworker to half show up for you. Like that's not fun. I'd rather them say no and either me do it myself or gather someone else to do it than to have someone who's not there 100%. To be an effective caregiver, you have to understand key aspects of like the declining process. So Sally was talking before about like what symptoms are normal, what requires intervention, what's beyond your scope, right? Making sure that you're staying calm and being reassuring and accessing, an example is like hospice or other professionals if appropriate. And then most important, perfection is not the priority. Presence is the priority. The human connection is the priority. We're going to talk a little bit about what to say, what not to say. This comes up all the time for caregiving. So the phrase for this is platitudes. It's like what people say when they're intending to be helpful, but it's really more harmful than helpful. Okay. So we're going to go through a few examples. I hear a lot of family caregivers say like it was meant to be. So what they're really saying is that you were doomed from the beginning, right? And that this is like fate. And what the patient experiences is like, well, then what's the whole point of all of this, right? Why am I bothering to keep going if I was just doomed? Or everything happens for a reason. So the messaging that's saying is that there's a lesson in this and that something good can come from this. And the patient's like, what good can come from this? And why do I have to be the martyr for this? And how much do I need to suffer in order for the reason to exist, right? Or winners never quit. That means that the patient's not allowed to stop treatment. That's what they hear. And that people aren't going to be happy unless they keep going, right? Another platitude is like, this one's controversial, so just bear with me. God has a plan for you. So I think this is, when people say God has a plan for you, I think we're trying to negotiate justice and fairness. And we're trying to kind of create order from something that feels chaotic for us. I think it sends a message that there is an assumption that the patient has the same theological perspective as you, and that they also believe that God has a plan for them. But it also doesn't leave space for chance if that's what the patient believes in. And the questions that kind of go through the patient's mind is like, why would God want me to suffer? What did I do to deserve this? And it kind of adds this whole layer of reconciliation. Another platitude is like, live each moment like it's your last. I think this sends a message that that they're dying now, which I think can be very scary if somebody doesn't have that super terminal illness, like imminent. It's like they might have a terminal illness and live for a long time. And I think it kind of contributes to fear in a way. Sometimes people will say like either God or life doesn't give you things you can't handle. I think it sends a message that the patient's somehow hoarding strength. And that if they kind of dig in there, they can muster it up and keep going. So the patient often will say like, well, how do they know what I can and cannot handle? If I feel like I'm at my limit, I'm at my limit. Another platitude is it could be worse. Other people have it worse than you. That's a rough one. My experience isn't valid. It doesn't matter. How sick do I have to be sick enough for you? I know, yuck. I'm watching everyone's faces. We hear it. Okay. So don't be in denial. Acknowledge the reality of the situation. Don't avoid talking about death or the dying process. Don't tiptoe around tough conversations. Don't avoid normalcy, because sometimes people are like, well, if I'm the only person that they're talking to, then they have to talk to me about it all the time. People don't want to talk about like death and dying all the time necessarily. Some people do, but some people just want to kind of continue on and talk about happy things and normal things and day-to-day operations. Don't compare one person's story to another. I hear that all the time, well, my cousin, has been living with this for 50 years and they're doing great. And some people like to hear that. Some people don't like to hear that. And on the flip side, well, my cousin died from that, like over, they like this, and you don't want to say that either. Don't suggest blame that the person somehow warranted this and took this, deserved it. And don't offer unsolicited advice. And don't say, I understand, because you understand nothing. Okay, these are things you can say. How am I doing? Okay. Yeah. If you feel, I have 2 different slides. So this is like if you feel super confident discussing end of life and or cancer, etc., you can say these things. And then the next one is, if you're not sure, if you're not comfortable, what are some suggestions? So if you're feeling confident, you can say, this must be difficult. I can't imagine how you feel. I'm so sorry you're going through something like this. I'm here if you want to talk. I think you can say like, it's okay. Like, people cry all the time. I know that you're probably depressed. That's okay. I won't take it personally. If you don't want to talk, you want me to stay, you want me to hang with you. I'm thinking about you. I care about you. You're special to me. And then if you're not comfortable, because it could be a little clunky, you can say, I'm not sure what to say. I've never done this before. Can you tell me what you want to talk about? I'm nervous about visiting you because I don't want to offend you or upset you. Is there something I should be doing? Is there something you particularly don't want me to do? The next one's a good one. So patients will often say to me that like either people overengage or underengage. And I think that it's really important to maintain consistency. So sometimes like at the very beginning of for the beginning of someone's like cancer journey, it's like everyone wants to contribute money, everyone wants to drive, everyone wants to help. And then all of a sudden it's like 5 years later, everyone's gone and they're over it, they've checked out. And that's like it's a sad situation. So like maintain your engagement. Sometimes people, which is bizarro, but sometimes people will say like, well, I called them 3 times and they didn't respond. So I just assumed that they weren't interested or that, they don't want to talk to anyone. And I think that just by calling and leaving a message is a nice thing to do. And you don't have to control the outcome. You can just, contribute in your way. Maybe the person's too sick to respond. Maybe they don't want you to see them in that way, but they are happy knowing that you're thinking about them. Okay, what you can do also is you can offer, I say very specific and concrete. So like, don't say like, I'm here, whatever you need, right? Because no one's going to respond to that. But if you say, I can bring you to your appointment on Mondays. Mondays, I'm totally free. Do you have any appointments on Mondays? Or do you have any food restrictions? I can bring you dinner on Friday. What have you had this week? Sometimes you'll have like food trains of like pasta every day, So saying like, have you had pasta every day? Or do you want me to bring you chicken today? That's helpful. What isn't getting done around the house? What feels overwhelming for you? I know you like to be independent. I don't want to cook for you if that's something you enjoy doing, but if it's something that's kind of like this hurdle for you, I'm happy to either come and cook in your house or, bring it over, all those kind of things. Okay, so I'm going to briefly talk about caregiver. Are we okay, by the way? Okay, we're going to briefly talk about caregiver burnout. So as a caregiver, you're probably under a lot of stress. You might be focused on providing care and support to the care receiver or the patient or whatever we're calling it for today. But when this happens, sometimes it's at the expense of the caregiver's health and well-being. Okay, so signs and symptoms of caregiver burnout. So there's lack of energy that comes with an overwhelming sense of fatigue, losing interest in activities that you typically enjoy. So like I used to go to the theater every week, and you know what, I don't even want to bother. Withdrawing from friends, family, other loved ones, feelings of sad or hopelessness or helplessness or that sense of doom that things won't get better, feeling constantly anxious or overwhelmed. We talked about neglecting your own health and needs, feeling that you're losing control over your own life, because we hear that a lot. So like we mentioned, like the example is like the sandwich generation, right? Is like you feel like the kids are being neglected, or you feel like your spouse is being neglected because you're focusing on somebody else. You might experience like changes in eating habits, like overeating, undereating, not paying attention the way you usually do, weight gain, weight loss, sleeping too much, not sleeping enough, sleep disturbances, nightmares. You might be feeling like impatient or irritable or resentful of other people around you, and also you might feel like a particular resentment to the person you're caregiving for, or vice versa. You might be focusing so much on providing care that you're resentful to everyone else because they don't understand you and you're the only one doing everything. And then there's like the physical symptoms, like the headaches, the body pains, the things that come with the body, like helping with body mechanics of all these people that you're providing care for. So all the things that it physically, hurts. And then we have like, we call them maladaptive coping strategies. So like using alcohol or sleep medication or things to help you fall asleep. Okay, so we talked about this, but it's kind of like a summary slide. So these are strategies to reduce the likelihood of burnout and also help recover once you notice the signs of burnout. So just as a friendly reminder, we mentioned it earlier, understanding your capacity as a caregiver is helpful for you. It's helpful for the person you're providing care for. I just want to highlight the emotional resilience because we touched upon it, but we didn't go into it last time. So caregiving can be emotionally heavy. It's best to normalize your own emotional responses. So if you're feeling frustrated, or you're feeling guilt, or you're feeling grief, or you're feeling exhausted, name it, right? Say what it is, because you can't practice stress management until you identify that it exists. So no one's going to start doing like breathing exercises or journaling unless you say, I'm anxious, I need to do breathing exercises or journal. You can do grounding techniques. You could do like the yoga, the meditation. We talked about music therapy, anything that kind of brings you back down. So for some people, it's like fitness. You do you, whatever keeps you calm. And then just as a reminder, you want to seek professional support, whether it's like an individual counselor. There's like 1 million caregiver support groups online, in person. Access people if you need to. And then the last part is like building a network of support. So we talked about that before too.
We're going to open up to questions if anyone has questions.
It's
So,
easy. It's an easy
just-
question. The question is,
yes, thank you.
yeah,
for
that's okay.
repeating it.
Are there any caregiver support groups? So I think it's very specific. Yeah, virtual. Well, in person and virtual. Yeah. And there's also like social media support groups, things like that. So I would say to go to one that's specific for the diagnosis of the patient, of the care receiver. So like a lot of times people will ask me, well, the patient also has cognitive impairment from dementia. I'm like, no, that's different. Let's do a dementia or a cognitive impairment support group versus like a cancer support group. And there's lots of factors too, I should mention. So like, caregiving for a spouse, at age 80 is different than, caregiving for a spouse at the age of 40, especially with variable diagnoses. So I think the more specific you can get, the better. Competing priorities, I think you're saying. So like if there's 2 siblings and they have competing priorities or competing agendas of how they want to caregive.
That's what it seems like.
Yeah. So one of the hardest.
Yes, she said that.
Yes. So one of the hardest things to do is that every family should have one spokesperson. So that spokesperson doesn't get to make the decisions, they're the spokesperson. So you gather consensus and then right? And then somebody has to be responsible for communicating it. So most important is that I'm going to make a hearty assumption that there's cognitive impairment because it sounds like decision making really shouldn't be for the caregiver. It should be the care receiver that's making decisions. So if they're talking about them making the decision, it's probably cognitive impairment and them deciding what they think that the care receiver would want. Yeah, that happens. Not every family is going to have 50-50. Right? And that's regardless of the roles and responsibilities. So like siblings, marriages, parent-child, it's not going to be 50-50. Right? I think that the goal is to, if you're the one that's contributing more, then the goal is to not be resentful of the other person and just know that their capacity is different than your capacity. So either they don't have the motivation, the interest, the knowledge, the skills, the finances, they're missing something that's preventing them from giving more. And that's just where their capacity is at.
Anybody else has any questions in the chat? And then does anybody else have questions in the room? No? Okay, there's another question, or rather,
Follow
someone
up?
in the chat says, thank you for offering this seminar. They're watching it for the future, but it's a welcome service. So thank you very much.
Oh, anytime. And you can feel free to connect with us whenever you need support, whether it's now or 10 years down the road. We cap it at 10 years.
Yeah, no, this was amazing. I'm glad
Thank
that you addressed the caregiver burnout portion because I think that's always there on people's minds, but where do you get information?
I'll tell you,
This is why-
it's very easy to identify when you see it in other people. You know what I mean? When somebody comes to the office and they're like screaming at the patient, you're like, oh no, like we could have stopped this before, you know? But they probably didn't identify it and they probably have tremendous guilt that stops them from saying, this is my capacity. That's okay.
Appreciate you guys.
Yeah, thank you so much
Yeah,
for coming.
Thank you.